going. My mandate was to cover the upper brain, and obviously, starting off, we must know, and that's why we are in the anatomy lab. If you do not know your anatomy, then you should be in business. You shouldn't be in surgery. You've got to know your anatomy, and because the emphasis is on endoscopic anatomy, it's an endoscopic course. It's important to convert that gross anatomy, microsurgical anatomy, into the endoscopic anatomy. The essence of today's endeavor for those who will come will be to focus on getting proficient at endoscopic third ventriculostomy and septostomy. Obviously, when you're in the ventricle, there is need to do a biopsy, there is need to do other procedures, but for this course, the emphasis will be on that, and there are models that are very nice that have been brought by Karl Storz, and we'll be dealing with that this afternoon. So we'll start off with endoscopic ventricular anatomy. Do we have a pointer? Thank you. Okay, fine. Thank you. So it's not moving.
Just click on the next slide on the left column.
So it doesn't move with.
Yeah, can you click on that?
Can we control it?
Does it move if you click on that? Click on that.
I could click on that, but I was wondering whether I can't just move.
It's moving. It moved.
All right.
Okay, it moved.
All right. Now we're ready. Okay.
Beautiful.
So, what are the indications where we will be doing endoscopic approaches into the ventricular system? The most common in our setting, of course, is obstructive hydrocephalus due to the variety of causes that we all are aware of. Aqueductal stenosis and childhood hydrocephalus is amongst the most common procedure that is done in our setting. Then one wants to manage arachnoid cysts within the ventricular system and also using endoscopy outside of the ventricular system. Colloid cysts of the brain, of the third ventricle is another indication. Biopsy of intraventricular tumors and tumors in areas adjacent to the lateral ventricle and the third ventricle. So these are the reasons why one would want to go endoscopically into the ventricle. Key to that, therefore, is the relationships that we need to recognize and understand. So the areas around the lateral ventricle, the third ventricle, and the fourth ventricle, less commonly we enter into the fourth ventricle, but we're always working within the lateral and the third ventricle. So therefore, we must know our relationships. The key relationships are outlined in this slide. We have your lateral ventricles. Adjacent to that, as you enter, you must be aware that if you're a little out of your position, you are at risk of entering or damaging the caudate nucleus. We have the thalami across there. And if you're way out, obviously there is the internal capsule, the globus pallidus, the putamen, and the claustrum are all, you can see them in gross anatomy, and you can recognize them in your MRI scans. So these are key relationships when you're entering into the ventricle. Internal capsule, the external capsule, the extreme capsule, subthalamic nuclei, substantia nigra, the hippocampus, are all in the vicinity or neighborhood of the lateral ventricle. And when you next see your MRI, we know that we tend to just go by axial views, but if you look at these coronal views, you will be able to recognize these structures and have them embedded in your memory when you're doing these procedures. ETV, the endoscopic third ventriculostomy, is the workhorse of endoscopic work, and essentially when one is starting endoscopic work in the brain, your endoscopic third ventriculostomy is the one that one needs to become proficient. And essentially it is done through a burr hole right in front of the coronal suture. And if you're pedantic about it, it is 12 centimeters, and in children with hydrocephalus, maybe 13 centimeters from the nasion is where you find the cochlear's point where you can do your burr hole. And that essentially has been chosen because when you're using a rigid endoscope, that line is the straight line between the basal cistern in front of the basilar artery and the foramen of Monro. Because if you're a bit further forward, you're going to struggle and pull upon the foramen of Monro, and on the fornix rather. And if you pull on or tag or damage the fornix, of course, the patient will have memory problems. So using that as a straight line, you see that you do not then target or damage the fornix going towards the basal cistern and right in front of the basilar artery. So that is your trajectory, essentially. The view as you enter into the lateral ventricle, as you enter into the lateral ventricle, and those who have been involved in endoscopy, the pristine because the hydrocephalus may be extreme, but what you're trying to look for is essentially this view. And the key to finding where you want to go is this structure here, which is the choroid plexus, this structure here, which is the thalamostriate vein. And sometimes you will see the septal vein on the septum, but if you see these two, where they join is where you really will find your foramen of Monro. And that is the view as you enter. You then get closer, and you then begin to see the fornix more clearly. As you begin to enter into the fornix, you get this view, and essentially that's the one that you want to find in an ideal situation. You want to identify your mammillary bodies and your tuber cinereum, and once you've done that, you then are able to perform your endoscopic third ventriculostomy. And then this is, so in an ideal setting, this is what you want to achieve. Get in, see your choroid plexus, your thalamostriate vein, your fornix, enter into it. You're entering into the third ventricle. As you enter into the third ventricle, locate your mammillary bodies and do your procedure. And we'll be practicing that this afternoon as to how to do that. This is a more detailed view of that anatomy, essentially showing us the foramen of Monro, the telachoroide, and the fornix. Now, what is the telachoroide? Essentially, you can look at it as the lamina propria of the ependyma. So these are folds of the ependyma. They are thin, highly vascularized, loose connective tissue portion of the pia mater found within the ventricular system. So if you look at it as the connective tissue within the ventricular system, and you look at that as the ependyma, essentially this highly vascularized loose tissue is what is called the telachoroide. In the lateral ventricle, it lies along the choroidal fissure in the medial wall of the ventricle. The blood supply, and this is important because if you damage these, then you can get into problems. Anterior choroidal artery off the internal capsule, internal carotid artery, and several choroidal branches of the posterior communicating artery. Posterior cerebral artery are what supplies the telechoroida. In the third ventricle, it is found in the roof and is supplied by the posterior choroidal arteries. In the fourth ventricle, it is located in the roof of the fourth ventricle and supplied by the inferior cerebellar arteries. Now, essentially, when you've got the ventricle, you are able to approach it, and in certain procedures, you have to approach it from above. And that it's important to, that's the one that we've just described. You can also approach the third ventricle endoscopically from in front, and that is through the lamina terminalis. Therefore, you should be able to perform ventriculostomy through the lamina terminalis as well. So this is a view. And then the third way of getting into the third ventricle is when you're doing skull base surgery and you're coming in from below, and we'll see that anatomy as well. So this is, that was the earlier one was the anatomy from above. This is the anatomy coming in from in front where the lamina terminalis is. And essentially, you can open the lamina terminalis below the anterior communicating artery. If that is your anterior communicating artery, you've got your A1s on either side. Your lamina terminalis is here. You can open up the lamina terminalis just below the anterior communicating artery. The A2 usually then ascends in front of the lamina terminalis to pass into the longitudinal fissure between the two cerebral hemispheres. So when one is doing an ETV, if your third ventricle is occluded or fibrosed or has a lot of fibrous tissue, you essentially can do an endoscopic third ventriculostomy through your lamina terminalis, and this is where you are targeting. The third ventricular entry through the lamina terminalis via the supraoptic chiasm route, these are the anatomical landmarks. So you've got your anterior communicating artery, you've got your two A1s, and that's your optic chiasm. And in there is where you can get into your third ventricle. So you can essentially have an endoscopic view from in front, entering into the third ventricle. Essentially trying to show you the anatomical landmarks around that area. The anterior wall of the third ventricle is formed by the lamina terminalis, as we've mentioned. The roof of the third ventricle is formed by the telechoroida, which then presents as the two extensions of the telechoroida, which is the choroid plexus. So essentially, you need to be very aware, just like we mentioned in the relationships, that working in that area, you're working near the anterior communicating artery, you're working near the hypothalamus, you're working near the massa intermedia, posterior commissure thalamus are all in the region where you are working. The third ventricular floor, which is this one, is essentially going into the third ventricle, and then you could get into the, then if you're going to, that's your posterior commissure, and this is the view from within the ventricle. The ideal view that you want to see when you're doing your third ventriculostomy is this. You see your mammillary bodies, you see your tuber cinereum, and you see your infundibular recess. Once you see this, you're pretty sure that that's where you want to be. And that's your most common. Not always easy, because in our setting, post-infectious hydrocephalus is quite a problem. But if you can identify the mammillary bodies, and mind you, in a lot of these hydrocephalic patients, they're fairly flattened out and it's not easy to recognize them. But if you can recognize the outline of medullary bodies, you know that that's where you want to do your endoscopic third ventriculostomy. Now, you can enter the ventricle while you're doing skull base surgery from below, entry into the third ventricle where the tuber cinereum. So rather than opening the tuber cinereum, going into the basal cistern, if you're doing skull base surgery, you can enter into the third ventricle via the tuber cinereum. Mind you, and this is important, it's an important landmark, the distance between the two posterior communicating arteries is usually about 11.3 millimeters. So you've got a centimeter plus where you really need to remain in the midline because you've got your posterior communicating arteries on either side. And that's the purpose of this slide, to show you that you haven't got a huge difference or huge distance between the posterior communicating arteries. So this is your endoscopic intraoperative view of structures of the foramen of Monroe. This is your ideal. As we said, locate your thalamostriate vein, locate your choroid plexus, where the two join is where you're going to get your foramen of Monroe. And right there is your fornix, and that's your anterior septal vein. Oftentimes, that is not the one that you go looking for. You're looking for the choroid plexus and the thalamostriate vein, and bang, at there, where they join is where your foramen of Monroe is endoscopically. Pretty much repeating what we've just said. So what you do need to identify when you get your endoscope in are these areas, and you must recognize them every time you do that. The mammillary bodies, you will see the pulsating basilar artery. You can then see the floor of the third ventricle, sometimes fairly opaque, but oftentimes that's the tuber cinereum, where you can then see through. The clivus is seen through the third ventricle oftentimes, and then you see the infundibulum, and this is the view. This is the view that you get in a pristine ventricle which is enlarged, the third ventricle that is enlarged. You see this, you're happy. Now, the membrane of Lilliquist, it's important to recognize that there are made up of two leaves. There is the diencephalic portion, which comes from the front, and a mesencephalic portion that comes from behind you, if you're standing at the head of the patient. One of the key shortcoming mistakes one makes is going through membrane of Lilliquist, thinking you have gone through, but you haven't gone through both leaves, and your ETV will fail. So you see your mesencephalic portion of your membrane of Lilliquist. That's your prepontine cistern. And oftentimes, if you see you've gone through one layer and you're still seeing another, you haven't gone into the prepontine cistern. But if you can see your basilar artery very clearly, not covered by any membrane, then you know that you've gone through both leaves of the membrane of Lilliquist. So there is the diencephalic portion, and there is the mesencephalic portion. So there'll be two leaves. Just remember, this is one leaf going onto the other. So you must go through both leaves before you get into the prepontine system. And once you get into the prepontine system, that's when you'll be able to recognize the posterior cerebral artery, the cerebellar artery. You'll be able to should be able to see them, but in most instances, what we're trying to get to is the prepontine system free of any Lilliquist membrane. Again, same message, membrane of Lilliquist, the diencephalic portion. You will see thalamic perforating arteries. And if you look carefully, and if there isn't too much scarring, you'll be able to see the third nerve and your posterior cerebral artery. So all these are beautifully outlined in a pristine. Now, an ETV has not been successfully done yet. You've opened up one membrane, possibly the mesencephalic one, but you have not opened up. And oftentimes an ETV will fail because you think you've gone through the membrane, but you're still left with this diencephalic membrane. Fairly easy to perforate with a balloon catheter because it will give way, but then dilate it, and then you'll see the vessels very, very clearly. You'll see the cerebella, but basically you want to see not the cerebellum, you want to see the basilar very, very clearly, unhampered by any of the membranes. The structures that you will then need to recognize are the clivus, of course, the membrane of Lilliquist, and a very unimpeded view of the basilar. And if you see this and you've got a balloon catheter, you can actually open these out so that you can get a good view. And then if you are going deeper, you will be able to see your sixth nerve and the anterior inferior cerebellar artery in that area. So that's where you are now reached once you've done your ETV. Very similar view. Now you're going further down. As you keep going down, you are able to see structures that are even deeper. You can go right down, if you have the right endoscope, to the foramen magnum. You can actually reach down the foramen magnum, see the medulla. You can see the vertebral artery coming up towards you, and next to it are the lower cranial nerves. You can see the hypoglossal. You can see the posterior cerebellar artery there, and the 11th nerve. So these are structures that you can actually go. Doing an ETV, you don't need to go there. Done your opening, you've got a good CSF egress coming in. You don't need to go into that area. This is just to indicate that if you're going down, you can go down safely just behind the clivus towards the foramen magnum, and those are the structures that one will see. That's your endoscopic view. So why are we saying this? Because this is pristine anatomy, your normal anatomy. If you recognize that, then you will recognize that there are variations that are often found. And all of us who have worked in sub-Saharan Africa and in areas where there's a lot of hydrocephalus, we recognize that it almost looks like the variations are what are normal in some of our patients. So variant findings are frequent and very varied in infantile hydrocephalus. These findings increase the difficulty and operating time. So one should not go in saying, this is going to be a 20-minute procedure or half an hour procedure, because in our setting, variant ventricular findings are almost the norm. Normal ventricular findings equate to shorter procedure times and success in accomplishing ETV. And a very good study done at the National Hospital by Ben, who said he was going to be here, Ben Okanga, actually showed that very eloquently. The times where and that led us to develop a grading system, which we call the African Federation of Neurosurgical Grading. We won't go into that now, but essentially, the higher the African Federation Neurosurgical Grading, the greater the difficulty of achieving success in endoscopic third ventriculostomy. That's for another day. So as in all surgical undertakings, the anatomy that's been outlined briefly in this lecture, it's important that a clear understanding of this anatomy is taken on board, and it's mandatory before you start embarking on neuroendoscopic ventricular surgery. Ventricular anatomy is prone, as we mentioned, to variant anatomy, especially so in the childhood hydrocephalus cases that we see in our setting. And recognizing these variations is just as important if we are going to be achieving success in endoscopic procedures. Thank you very much.